Hello and welcome to another episode of A Slice of Health, the Candid Health Chat podcast, where we slice away health truth from health fiction. Join me and my friends as we challenge common health myths via chit chat, powered by several cups of coffee. Don't forget to subscribe and follow us on social media, and do visit us at asliceofhealth.club. Let's get to today's episode. On today's episode, we are going to be addressing a recent episode where we discussed the stigma of contraception in Nigeria. Dr Adebola Adisa is going to be joining us to do a rebuttal demystifying contraception. Dr Adebola Adisa is a GP in the northeast of England. She obtained her medical degree from the foremost University of Ibadan, Oyo State, Nigeria. Dr Adisa is also an author and has written 3 books: The Magic of Destiny under a pseudonym Jessica Dice, Kaleidoscopes, and her latest book is an e-book, #BeInspired. She also writes on social media where she promotes healthy behavior and increases awareness about health conditions. Welcome, Dr. Adisa.
Thank you for having me.
Thank you for joining us today. So today we're talking about the recent episode that we did in Nigeria, talking about the stigma of contraception in Nigeria. But just before we go ahead, could you just tell us a bit more about yourself and why you decided to become a GP?
Right. So in Nigeria, when I finished from UCH, and I always wanted to go and specialize in preventive and social medicine, which is PSM. But it was one of those competitive fields. So even after doing my primary examinations and tried getting a place anywhere, it wasn't happening. And at that point, I had already done my exams to be able to work in the UK. So I just thought, why not? The opportunity is not coming here. So, and somehow it was fairly, straightforward to come and be in the UK. So when I got here, I initially worked as like an SHO, which is like just being a medical officer. Mm-hmm. And then I realized that I could actually specialize. And of course, the first thing that came to me was become a GP. And that's, I think, as close to being a preventive and social medicine specialist as you can be, I think. And I've not regretted that decision.
Oh, that's great. That is awesome. So thank you for being on the podcast again. So I think we were just discussing before we started recording that you'd had to listen to the episode talking about the stigma of contraception in Nigeria. Did anything stand out to you in that episode?
Yeah, I found it very interesting, the participants, and the conversation was really very good, and I think it addressed quite a lot of issues. What I think is, having lived in Nigeria and now being here, I have some different views about some of the things that were talked they spoke about, that they discussed. I think there are quite a lot of myths, obviously, about contraception, but what's been addressed, the fact that there's poor access, and of course, poor access leads to unwanted pregnancies, and unwanted pregnancies mean safe abortion services, because, it's not exactly legal to abort pregnancies in Nigeria. So it's all a kind of a cycle of myths, which I would classify as ignorance, and then the disease, which I'll classify as unwanted pregnancy, sexually transmitted infections, which was one aspect that wasn't really addressed, which I think is equally important. Yeah. But yes, I think the participant addressed all the things that are important, but one thing that struck me was where somebody said about abstinence. Obviously, abstinence is quite important, and it was picked up that most people are having sex, whether mentioned or not, whether anybody says it or not. And what's important is, if they're having sex, they do have to have access to prevent pregnancy if they don't want to be pregnant.
Yes.
unfortunately, it's in the same area where there are poor abortion services, poor health services, that there is poor access to contraceptive services, which obviously it just triples or multiplies all the complications that can come from that poor access. So that's has been addressed, and that's what I would emphasize, that we do need to be looking inwards. I know all over the world there are different things that are implemented to make health easier, health safer for women, for children, for all the people that need those services.
Yeah.
But we need to be looking inwards. What can we do in Nigeria, for instance, that will address those issues? We cannot depend on what's available. We need to be legalizing abortion, but as it is, even the provision of basic health services in Nigeria is virtually not there. Where it is present is very expensive and inaccessible anyway.
Yeah.
Why don't we concentrate on preventing unwanted pregnancies? Because right now, provision of basic services, not to talk of abortion services, is like impossible. So what we need to be focusing on, I think, for Nigeria is demystifying those things that say, oh, I won't be able to have a baby when I'm ready to get pregnant, when I get married, or that belief, religion, which is driven by religion,
Yes.
that everyone should be abstaining. That is impossible.
Yes.
It won't happen in a million years. So why don't we work towards making everybody know that it's their right
Yes.
to have contraceptives.
Yes.
It's their right if they want it, and it should be accessible everywhere. It should be, in pharmacies, it should chemists, it should be in anywhere possible where you wouldn't feel like if it's in toilets where you can just dispense it. Nobody even has to know that you're buying something. You don't have to be scared or feeling vulnerable to have to walk into somewhere to get them. So I think for me, we should work more on the accessibility and demystifying the reasons why people should be having contraceptive services. So I think that's the area I would like to also emphasize on.
Definitely, and I think that's great. I'm really glad that you came in that direction, because so you've mentioned a couple of things. You've mentioned that abstinence is the promotion of abstinence as a means of contraception is not effective, which is, I think, a very important thing. So people who are pretending to be abstinent while engaging in sexual activity really need the information to say, actually, I don't want to get pregnant, but I want to engage in safe sexual practices. What can I do to prevent myself from getting a sexually transmitted infection? And what can I do to prevent myself from getting pregnant when I don't want to get pregnant? So I think that's really important. And then you said something also about sort of accessibility. So I did a very little test when I was there. And obviously I was only there for a very short period of time. But I walked into two pharmacies. Just picked at random, just opportunistically. And I asked for the morning after pill. And I asked for a combined contraceptive. And they were both available. And they were both very cheap. And they were also both very cheap. Obviously, I suppose what I would classify as cheap to a Nigerian in certain economical constraints, depending on sort of what social class they belong to, that might not be cheap for them. But it was definitely available in those pharmacies. And I suppose we might just then need to do a sort of a broader study in terms of, okay, how many places are we actually going to go to, multiple people. But I went in there as a woman without a wedding ring on my finger, which was one of the issues that was raised in that episode. And one pharmacist was female, one pharmacist was male, and they did not give me a negative attitude. They were very professional. They told me what to take, how to take it, what to do if I got sick or any problems with that as well. So I think that might also be a thing in terms of letting people know that actually there are places that you can walk into and easily get certain kinds of contraceptives. But let's talk about maybe demystifying contraception a bit more, Because I think that was something that came up quite a lot in terms of people saying, oh, but a lot of contraceptives have a lot of side effects. They have a lot of complications. They delay fertility. And that was something that I did try to challenge in that episode. Actually, that is not absolutely correct. And, there's one particular one that we do know delays fertility, but most of the others are not actually in that same category. So could you tell us a bit more about the common contraceptives that are available that we can use, and which one specifically is likely to delay fertility in general situation?
Okay, thank you. Actually, before I address that, it's actually good. You did that test and the outcome of it was quite favorable. I
Yeah.
do wonder if this was Lagos, which is more cosmopolitan, and
It
it may
was,
not have the same
yeah,
experience.
exactly. Yes, exactly. It was Lagos.
Well,
Yeah,
it sounds to me like we're getting there, and that is good, actually.
yeah, yeah.
So, coming to the types of contraception and contraceptive services are available, they're quite a variety, and that is quite good because during your last discussion, one of the things that was mentioned was some may be good for some people and some may not be good.
Yeah.
And there's quite a variety in such a way that you will likely find one that would suit you.
Yes.
You will likely find one that would work best for you, less side effects, less complication, less risk.
Mm-hmm.
So that is quite good. So there are some which are, as we know, they're condoms and femdoms, which are the female versions. And these are quite good if they're used properly.
Yes.
If the condom doesn't burst, or is not pierced, then it is safe.
Mm-hmm.
As we know, the thing about contraception, which also was mentioned, was the only 100% one is abstinence.
Yeah.
But we all know that cannot happen in most. So we need to be looking at the other options, which are less than 100%.
Mm-hmm.
But some of them are quite safer than the other. So I think I should start with the withdrawal method, which was mentioned. That one is really, really unsafe, to be fair, because when do you know when to withdraw? There is something called the pre-ejaculate, so which means that there might be a release of the sperm before you even thought you had ejaculated. So that is very, very unsafe, and as far as I'm concerned, should be avoided as much as possible because it's unsafe. That's the truth.
You can't rely on it as well. So
No, you can't rely on that at all as a means of contraception. It's not even near a good percentage to rely on, to be fair. So condoms, femdoms are quite good if, like I said, if they're used safely. And the good benefit of condoms, which other contraceptives don't have, is it can also prevent sexually transmitted infections, which is very, very important because especially in young people, if they do then develop sexually transmitted infections, which includes HIV, those are issues that then you then go on to develop pelvic inflammatory diseases, and that's when you might then have issues with infertility. So condoms are quite good, and actually, if this is something that one needs to look, if you are having sex with someone regularly, are you safe with them? Are they a regular partner? All those things need to be addressed because condoms are the only ones that would prevent sexually transmitted infections. Now, moving on to the other ones, there are the ones that are, everyday, like pills, and there are the ones that are more longer term things, so long acting reversible contraceptives, which means that you don't have to remember to take them every day. So there are the pills. I will come back to that. And the ones that are non-pills, they are often the ones that are like the injectables, which are the depot injections, and then you have the subdermal implants, which are the Implanon and the likes of it, which can be put just under your hand. And then you have the coils, which are also different types of coils available as well. Now, coming back to the pills, those contain hormones. And there is the combined oral contraceptive pills and the ones that contains two hormones, the estrogen and progesterone, which are the natural hormones in the females, which help regulate, release of eggs and things like that. And in that way, depending on what's in the pills, can prevent you getting pregnant. Now, there is the one that's got only one hormone in it, which is progesterone, and that's also comes in different forms, but we're talking about the pills now. Now, I know you mentioned something about going into the chemist to go and buy a contraceptive. Was it a combined contraceptive?
So what they had was combined. Now, obviously, that is also an issue in terms of the scope of how much they have. The specific combined one that they have goes by a trade name, so I don't want to mention which one, but it is a common one that is used worldwide. But obviously, I think the issue with that as well is when we normally do contraception issuing, we do a lot of counseling alongside it as well. So you need to take a full history from different people and ascertain their risk factors. So I think that is the issue with walking into a chemist to pick up certain contraceptives. And that's why a family planning setting is more appropriate, or seeing a doctor that understands what they're doing is definitely more appropriate. But in a setting like Nigeria, where there's so much strain on the health economy already, I think they're just trying to make it accessible in as many ways as possible. And let's not forget as well that in Nigeria, you can walk into a chemist and pick up Kefalexin, which, so, you can so in Nigeria, you walk in and pick up, quite strong antibiotics or limited use antibiotics. And those things are not really regulated.
So, I mean, you did ask me to say which ones will stop people getting pregnant for a bit. So, and which one that was in the last discussion is the Depo, which can delay pregnancy, for a year and a half average, thereabout. Again, which is why it's quite important. If you are going to be getting contraceptives, it needs to be done through a provider. And that provider can be a nurse, can be a doctor, can be a midwife, as long as it's someone who is trained to provide it. I believe in Nigeria should even be a pharmacist. Because we've talked about the strain on the provision of services. How many doctors are available to a population? So there's no way only doctors can be providing these services. As long as people are trained to identify risk factors, complications, contraindications. Because coming to something like combined oral contraceptive pills, there are certain risk factors where it's a no-no. The benefit of taking that contraception is not good enough compared to the risk, where the risk or side effects will outweigh the benefits for you. You shouldn't be taking it. But if it's in a situation where you walk into a chemist and you can literally, and possibly you're someone who has a very high risk of and complications already, where you shouldn't even be taking it, that is another problem, actually. So it is tricky. It is a tricky thing in Nigeria, where there should be a balance between accessibility to these services, as well as proper, it needs to be properly done. It's not just about it being available. It needs to be done safely.
Definitely. I definitely agree with you in that, in terms of the safety of it. And I think that is probably something that we should also discuss in terms of contraindications, because when I got a lot of messages after that last episode, and some of them were doctors in Nigeria saying, oh yes, but they don't like contraceptives because they have so many complications and contraindications. And I think if this is the pervasive mentality among healthcare workers, then if that mentality already exists in your healthcare worker, then that also becomes a barrier from you receiving the right kind of contraceptive. And so if you are already, seen as someone who is doing something wrong in that society, where abstinence is encouraged if you're not in a heterosexual marriage, then you then have a lot of barriers to actually accessing something that is going to be, number one, beneficial for your health, and also number two, helpful in preventing you from getting pregnant. So why don't we talk about the common sort of side effects and contraindications to contraceptives. And what I'd like us to do is actually start from the long-acting reversible contraceptives. So the ones that stay in long term, you don't need to take a tablet every day. And these are also the ones that also seem to have a lower side effect profile and complication profile compared to the pill. So should we start with the copper coil, because that's one that's been around for several generations. So what complications would you say arise from the use of the copper coil, and in what situation would you not want to prescribe that for a patient?
Okay, so copper coil, these are long-acting reversible contraceptives, like we mentioned already, and they last quite a long time. It's average of about 7 years, 5 to 7 years, sometimes even longer, but that's, reasonable time length. And they will stay in for that length of time and keep protecting you and keep preventing pregnancies. Now, they obviously have side effects. For instance, if you have a history of pelvic inflammatory diseases, that can predispose to that. And because of that, there's also the risk of ectopic pregnancies in the copper coil. So these are risks. Obviously, if you're allergic to copper as well, you cannot take that, because it is a copper coil. So it is actually the only contraceptive to a large extent which hasn't got hormones in it. So for someone who doesn't want hormones, so people complain about it makes me gain weight, breast tenderness, and all the the side effects of hormones. This is the one that you can take that hasn't got hormones in it, and it is quite good as long as you haven't had pelvic inflammatory disease, or you are not likely to, you don't have risk factors. So there are certain risk factors. So if you have multiple sexual partners, there is increased risk of developing sexually transmitted infections, which then it can make this quite unsafe for you. But to a large extent, it's well tolerated. If those, which is why you would have gone through the risk factors with the provider anyway. Same as the Mirena coil, this is a very good one as well. If you're someone, for instance, if you wouldn't be remembering to take pills every day, it stays in for about 5 years. The benefit of this is it also helps regulate periods. So some people actually have the Mirena. Well, Mirena is a brand of it. There are different types. It's the contraceptive, the other one, but it regulates periods. And in fact, some people use it just to regulate every period, because they have proper to every period. And once they put that in, that sort of regulates their periods. Some don't get any periods with it. Some, if they do get periods, it will likely to be regular periods. And it's quite safe as well. It's got hormones in it, one hormone, which is a progesterone.
And it's locally released as well.
Yes. So, I mean, there are, complications with things like this there, because it's going to be put, inserted into your womb. There can be a risk of perforation, but this is a small risk. But, if you're going to be having this, you will be told about it and counseled accordingly. You don't need to be scared. These are very good forms of contraceptives, because you don't need to remember. Even if you forget, it's not an issue, unlike some other types of contraceptives. There's also the subdermal implant, which is quite safe. It's one of the ones that are quite near 100% safe. In terms of effectiveness, you're very unlikely to get pregnant with this one. Again, because it would involve a sort of needle. They will need to sort of numb the area in your hand where they put it. So if you're someone who fears needles, and you won't be able to tolerate that, you may not like it. But if that's not an issue, it lasts for about 3 years, average of 3 years. It's quite good. The issue with this is it contains progesterone as well, which is one hormone. Some people have erratic periods with it. It's quite, many people don't. They have regular periods or no periods, but some people do get erratic periods with it, where they're like, it's not working, we need to get this out. And there's also the depot injections. There are different types of this as well. There's some that last for 2 months. There's some that last for about 12, 14 weeks, 3 months. And this would involve injections,
Yeah.
And again, if you're someone who doesn't like injections, you might not want this. But this, some women just they don't want something long term, such so like 5 years or anything like that. They want something shorter term, but not every day. So this works for them. Yeah, but like we said earlier, this is the one that can delay
fertility.
pregnancy.
Yes, and I think it's really important for us to emphasize that the ones that we've talked about so far, so the copper IUD, which is an intrauterine device, the intrauterine systems, which release progesterone directly into the womb only, and the progesterone implant, which sits just a little bit inside the flesh in the arm, in the non-dominant arm, are actually very quickly reversible. And so once they're removed, we normally expect that fertility will return to baseline. But the only exception to this rule is the injection, which you need to go for regularly, either 2 monthly or 3 monthly at your healthcare provider. So let's talk a bit more then about the pills, because with pills, there's so many pills. So even with the, so there are 2 different kinds of pills. We have the combined contraceptive pill, like you mentioned, which has 2 hormones, the 2 natural hormones that exist in a woman's body. And then there's the other one, which used to be called the mini pill, which only contains progesterone. But even in these 2 categories, we've got tens and tens of different combinations. Can you tell us a bit about this and how you choose which one for your patient, or do you sort of do it by trial and error?
I think the general rule is so now you need to sort of do a quick assessment. So based on history, if combined pills are going to be safe for someone. So things like if they've got a family history of blood clots in the legs, for instance, or anywhere, even in the lungs, or if they've got family history of like breast cancer. Now, this is not an absolute risk, but you do need to know. So you do need to carry out a risk. So if they smoke, for instance, if they have migraines where they are seeing things in their vision, or they're seeing spots, which we call migraine with, aura, the ones that they know beforehand that they're going to have a migraine. So that certain type of headache, migraines, which are headaches, we go through that risk assessment, and there's something we call UK MEC, which helps us to give that risk. And it tells us if they're going to, if the complications are likely to outweigh the benefits, in which case, we suggest to them that actually you shouldn't be on it, and we really don't want to prescribe it. Now, if they are safe enough to have combined pills, they are quite good actually, because there are also other benefits to it. So for people who have acne.
And what about the, so those are really important things actually that people need to speak to the healthcare provider about. So is there anyone in your family that's had blood clots? Have you ever had any blood clots? History of cancer, breast cancer, especially ovarian cancer, any risk of stroke or heart disease as well in the family? Really important things. Your smoking history, your BMI, so that's the ratio of your height to your weight as well. And these are the things that then increase what we call your cardiovascular risk, depending on the use of combined contraceptives. And then we then come into the what we used to call the mini pills, so the progesterone only pills as well. So which patients do you then choose to suggest that, okay, this is the appropriate one for them?
Okay. So progesterone only contraceptives, interestingly, most of the long-acting reversible contraceptives also contain only progesterone. Most of them do, and this is only one hormone. So for someone who we say is contraindicated from having combined pills, then the next best thing is the progesterone only. If they, and the type that they want to know what's happening every day. For instance, they are the people who are so well organized, they want to take their pills every day, they feel like they're managing their own contraceptive service by themselves, and they want to take it every day, then this is good for them. Obviously, with progesterone pills, it's quite unpredictable in the sense of how your periods are going to be.
Yes.
Some people are extremely, happy with it because they don't have any
Any
periods
period at
whatsoever,
all.
and they
Yes.
don't want any periods anyway. But
Anyway.
interestingly, some people get, their periods regularly, which they
Regularly.
also like. But
Yeah.
some people, they have erratic periods where they might
Yeah.
have a period today, the next 2 weeks, another period comes and it's heavy, and they just don't like it. If it's
Mm.
that's the situation, they may need to change it.
Yes.
So, there is a huge variety of contraceptive services, like we mentioned, and that's very good because it means that each woman will
As a choice.
likely find something that will be best to them and will work for them.
Mm.
I think that we should also not forget sterilization,
Yes.
which, which yes, which some women prefer if they say, I know I'm not going to have children anymore, and I
Yes.
do not want that mistake to happen at
Yeah.
all, and I
Yeah.
don't want to take any medication.
Mhm.
Then that's the one for them. In which case, they are sterilized.
Sterilization.
And of course, there's vasectomy, which was mentioned extensively earlier.
Yeah, yeah,
For
which
men.
definitely needs to be a topic in itself as well. In certain communities where men feel really linked to their virility, their ability to have children in most
Yeah,
situations. But I think the really great thing though is that there's so many options, and so if a woman is counseled appropriately, whether she's had children before or whether she hasn't had children yet, she should be able to find something that works. I mean, the diaphragm is an option.
absolutely.
There's still the transdermal patches as well that some women still choose to use as well.
Yes,
And there's still the vaginal rings as well, which some women still do prefer.
yeah,
So there are quite a lot of options. And I think it's really important for us to actually make that really clear that there are options. Let's sit down and let us talk about it. I think that is potentially what might be
yes,
lacking
absolutely.
in the Nigerian society. So, what would you say to, let's say, a girl in Nigeria, or even potentially a girl in the UK here who comes from a family of Nigerian parents or with Nigerian, that kind of mentality where there's just this huge stigma around contraceptives, and there's this pervasive mentality that if you use contraceptives before you start having children, you will not have children. What would you say sort of as a take-home message to people?
Okay, so which we've been, emphasizing, if you're going to be having contraceptives, it's best to go to a certified provider. So when you see that provider, who could be a doctor or a family planning practitioner, what we need as practitioners to be saying to people, especially to younger people, because they're having sex anyway, and when they come and see you for contraceptives, they are not coming for counseling
Mhm.
about their sexual life.
No, they're
They
not.
are coming to you for the provision of contraception. So you must not be judgmental as the first thing.
Yes.
You must, even be empathic in the sense that see yourself in the position of this young person. If it were you, and you have the guts and eventually summon the courage to even attend anywhere, the first thing you need to be doing is making them feel at home,
Yes.
and say, making sure that your face is very welcoming. You've come, I'm here to help you, and making sure you tell them that this is confidential. So even if you knew their parents, they're distant relatives by any means, or they've approached you as someone who is expected to keep their information confidential.
Yes.
So that is important, and you need to be telling them this. What you have come to tell me about today is confidential. Obviously, there's a caveat to that. If they're really young, they're below the age of sex, and they might, if there's a safeguarding issue. For instance, if maybe they're sleeping with an older person, or they're vulnerable, they're being abused, you will need to to be helping them with this area as well. If
Mm.
there's none of these safeguarding issues in place, if this is not an issue, of course, then they need to know that you're going to be very thorough, you're going to be empathic, and you're going to help them basically.
Yes.
So you need to be telling them that actually, apart from the depot injection, which you will not even be encouraging in a young person in the first instance, then every other type of contraceptive is as safe as possible, but it needs to be individualized, obviously. Is it
Yes.
safe for that person? And if it is safe, then you should be prescribing them to them, and these things need to be accessible, basically,
That is
to people who need them.
great. And in terms of, so if we were to present the, let's say the Department of Health in the Nigerian society with, I don't know, a structured plan to say, okay, let us try to improve contraception. Because one thing that some of the doctors were saying was that in addition to the mortality rate, the maternal mortality rate in Nigeria, 15% of that is actually from unsafe abortions. And so what can we, provide the department and say, okay, well, this is our strategy. What ideas would you sort of give, especially in environments where people believe that having more children is a sign of wealth? Having more children is protection for their old age in case if one child dies or another child dies. How do we address these issues that continue from generation to generation about the use of contraception and having multiple children?
I'm glad you said, the second to last statement about some people believe having many children is a sign of wealth and things like that. In fact, the whole point of contraceptives is the fact that pregnancy itself puts a woman in a very vulnerable position, and in fact increases their risk, of health issues.
Yes.
So the whole point of contraception is because pregnancy is not a disease, but many people are at risk of poor health because of because they are pregnant. And so if they don't need to be pregnant or they don't want to be pregnant, they shouldn't be pregnant. Yes. That's the whole essence of it, because they're safer when they're not pregnant, when they don't want to be pregnant.
Yes. Yes.
So we need to be presenting facts to the policymakers. We need to be presenting the reality on ground is that people are dying because they are getting pregnant when they don't want to be or they shouldn't be. Even if you say that, abortion is not legalized, the fact, which was quoted anyway, is 450,000 abortions are happening every year regardless.
Yes.
Which is probably an underestimate, really,
yes,
I think.
Yes. We don't know.
The abortion is happening anyway.
Yes.
So which means it's going to be unsafe abortion because it's illegal abortion, and people are going, there's a saying that a woman will do everything to get pregnant if she wants to get pregnant, and she will do everything to get rid of a pregnancy if she doesn't want to be pregnant. So they're still going to look for someone who's going to do it. A quack, someone who's not even medically trained is going to be committing this abortion, and people are going to be dying. They're going to get infections. They're going to have sepsis. They're going to die from this one said, abortion. So we need to face the reality, I think, on ground is that we need to sort these problems out. A healthy woman, a happy woman is a healthy nation, really. If we're struggling to even provide basic health care, then we need to go to the beginning, which is provision of, contraceptive services available to everyone who wants it, and it should be even cheap or, if possible, free. But let's not even talk about free. Let's talk about really cheap, so that anyone can access it. Safely. It's a fun. As far as I'm concerned, it's a fundamental human right.
Yes, definitely.
If you are in a position to decide that you don't want to get pregnant, it is a fundamental human right of anyone, any woman. I think.
Okay, that is awesome. Thank you so much for that charge. It's been really, really great having you on. Thank you so much. That was Dr. Adebola Adisa talking to us about a rebuttal on the stigma of contraception in Nigeria and debunking the myths associated with it. Thank you for joining us on today's episode. Remember that this podcast in no way replaces the advice you receive from your own doctor or physician. Don't forget to subscribe and follow us on social media. Leave us a review on iTunes so that others can access the amazing content. And do join the club at asliceofhealth.club, where you will also be able to access the profiles of the guests we've had on today. And don't forget to be a health champion wherever you are by separating health fact from health fiction.